Okay, so the next drugs we have are the thionamides. Thionamides are basically drugs that inhibit thyroid hormone synthesis. So as you guys know, we usually, the main enzyme we have for thyroid hormone synthesis is thyroid peroxidase, right? And this enzyme is a multifunctional enzyme, so it contributes to the oxidation of iodide into iodine, and then organification of iodine along with tyrosine in order to make the MIT, DIT, and then the T3, T4, right? The propylthiouracil or PTU and methimazole, both of them inhibits the TPO or thyroid peroxidase, which is the enzyme that's most important for thyroid hormone synthesis. Not only that, they also inhibit the 5' deiodinase in order to reduce the peripheral conversion of T4 to T3, right? And remember deiodinase because it removes one iodine molecule from T4 to make it T3. Okay, so basically it's very important and very nice for hyperthyroidism. It treats it very well. Okay, so what is the clinical use? When you inhibit the thyroid hormone synthesis, then that's treatment for hyperthyroidism. Okay, and there is something about PTU and methimazole. They are both used in pregnancy, but propylthiouracil is used in the first trimester, first trimester, and methimazole is the middle and third or second and third trimester. You have to know this very high yield. Okay, so PTU, primary pregnancy, or first trimester, primary, right? We usually write primary like this. So P for P, propylthiouracil, and propylthiouracil and primary, right? So first trimester. And methimazole, middle and third. Middle means the second trimester, and third is the third trimester. And here you have methimazole, middle and third. Okay, so it's pretty easy to remember. And also, there is something called PTU-induced hepatotoxicity. So propylthiouracil could induce hepatotoxicity in patients in the second trimester and third trimester. That's why we use methimazole instead. And also, methimazole is a very bad teratogen in the first trimester. As you guys know, in the first trimester is when organogenesis happens. So all the organs are made, but after that, there's no danger on organogenesis at all after that, right? You could have some different types of teratogens, but it's not like the first one. So methimazole, middle or second and third trimester, propylthiouracil, first trimester. Okay, all right. Thionamides, what about the adverse effects? The highest yield one is agranulocytosis, and that's why we keep doing CBC along with treating patients with hyperthyroidism with thionamides to make sure that there is no agranulocytosis that happens. You might get aplastic anemia because of the effect of these drugs on the bone marrow. You also can get hepatotoxicity, like we said. The PTU usually cause hepatotoxicity. Also, PTU has been associated with ANCA positive vasculitis, so P4 positive, ANCA positive vasculitis, PTU. And methimazole is a possible teratogen and can cause aplasia cutis, which is basically loss of hair and part of the skin in it looks like this. Let me show you guys how it looks like. So here it is, aplasia cutis. You're losing a part of the skin and hair. Okay, this is how it looks like. So methimazole could basically cause this. Okay, PTU, positive vasculitis, and agranulocytosis, aplastic anemia. These are very important side effects as well. Okay, so exactly. Short-acting regular insulin is used for DKA, hyperkalemia, and stress hypoglycemia. Good job. Okay, metformin. Good job. Okay. Also meglitinides. Okay, meglitinides have the same effect. The last question, glucose-induced insulin secretion, is GLP-1 agonists or the DPP-4 inhibitors, because I'm talking about oral glucose-induced insulin secretion. Also DPP-4 inhibitors, like here. Good job. Guys, is there any background noise here? Can you hear it or no?
Little, but
a little bit. How about now? All right, levothyroxine and liothyronine, both are hormones, thyroid hormones. Levothyroxine is T4, so levo 4 letters, lio 3 letters, so T3. Okay, levothyroxine and liothyronine. And then you need to avoid levothyroxine with antacids, bile acid resins, or ferrous sulfate, because they can reduce its absorption. Just put this information in the back of your head. It's not really important to recall that whenever you think of levo and lio, but just put it in the back of your head. So if you see a question about it, you already know it. Okay, so levothyroxine could bind to these agents and prevent the reabsorption or reduce the reabsorption. Okay, so levothyroxine and liothyronine, the clinical use is hypothyroidism and myxedema, of course, because you're replacing, it's hormone replacement therapy. And it may be misused for weight loss, right? Because this increases the metabolism, the basal metabolic rate, so it may be abused just like GLP-1 agonists, okay? And how to differentiate between exogenous hyperthyroidism from endogenous. So we use a combination of tests and in order to differentiate between the two. So exogenous hyperthyroid symptoms because of levothyroxine or liothyronine would have reduced radioactive iodine uptake because you're taking exogenous thyroid hormones, and you will have decreased thyroid blood flow because you're not using the thyroid gland anymore, and you have low TSH because you're giving the patient thyroid hormones from the outside. On the other hand, if somebody has Graves' disease, he will have positive TSH receptor antibodies, which will be, endogenous hyperthyroidism, not exogenous. So what are the adverse effects? Of course, tachycardia, heat intolerance, tremors, arrhythmia, which is basically the symptoms of overactive thyroid. Not a big deal. Okay, so some drugs that we talked about before, conivaptan and tolvaptan, they inhibit the ADH receptors at V2 receptors, basically the receptors that ADH bind to on the collecting duct to increase water reabsorption, free water reabsorption. And it's important in the treatment for SIADH, or syndrome of inappropriate ADH secretion. So we inhibit the effects of ADH on the collecting ducts in order to prevent the continuous reabsorption of water. So conivaptan and tolvaptan. Demeclocycline is the same thing as well. So it treats SIADH, and it interferes with ADH signaling. Okay. It's not a direct antagonist, it just interferes with the signaling. And in fact, demeclocycline is a tetracycline antibiotic, so it's an antibiotic, but has this side effect. Desmopressin is ADH, right? So we give patients desmopressin if they have central DI, von Willebrand disease, sleep enuresis, hemophilia. For now, just before we go into these are in the hematology section, so just for now, no central DI that we use desmopressin for. Growth hormone, if somebody has growth hormone deficiency, or in Turner syndrome, because in Turner syndrome they have growth deficiency, so sometimes we use growth hormone to treat Turner syndrome. Oxytocin will induce labor. Like we said, it's a muscular hormone, so it causes contractions of the uterus, right? And it controls the uterine hemorrhage. So basically the structure of the uterus muscle is that it looks like an 8 like that, okay? And in between these smooth muscles, you have blood vessels inside. So whenever these smooth muscles contract, they basically compress the blood vessel. So they prevent hemorrhage. So the contraction of the uterus prevents hemorrhage. So if a pregnant female underwent postpartum hemorrhage, for example, we could use oxytocin to constrict these vessels by contracting the uterus. Okay, so it controls the uterine hemorrhage. Somatostatin, basically we shut down all the hormone secretion, so acromegaly, carcinoid syndrome, glucagonoma, esophageal varices. And esophageal varices, like we said, if you guys remember, we have portal hypertension. So if we have the splenic vein here, the inferior mesenteric vein, right, and superior mesenteric vein, and you also have the esophageal branches here. So if somebody has esophageal varices in the esophagus, we could use octreotide to vasoconstrict the portal vein or the splanchnic vessels to decrease the portal hypertension, so to lower the effect of portal hypertension on esophageal varices. And I think we already talked about that in the GI section. It's very high yield. Okay, fludrocortisone. From its name, fluid cortisone. So it's an analog of aldosterone. It looks like aldosterone exactly and has the same functions. Okay, so fludrocortisone retains fluid. It reabsorbs two things and excretes two things. Reabsorbs sodium and water and excretes potassium and hydrogen. Clinical use is mineralocorticoid replacement in primary adrenal insufficiency. So people who have primary adrenal insufficiency, they cannot release cortisol or aldosterone, so we replace the aldosterone with fludrocortisone. And adverse effects, it could bind to the cortisol receptors and act as glucocorticoids. It also could lead to edema because you're retaining water, exacerbation of heart failure, and hyperpigmentation since you are decreasing the ACTH. You're screwing the ACTH, right? Okay, the last two drugs we have, actually the last three drugs we have sinacylate. Okay, it's a hard name, but it basically inhibits the calcium sensing receptor on the parathyroid hormone, the parathyroid gland. Let me remind you of this. So this is the thyroid gland. You have parathyroid glands, 4 parathyroid glands. and you have a calcium sensing receptor. And this senses the hypocalcemia, right? Whenever a patient has hypocalcemia, these calcium sensor receptors sense the hypocalcemia and start releasing parathyroid hormone. So sinacalcet, basically, it inhibits that calcium sensor receptor. Here it is. So it sensitizes the calcium sensing receptor to the circulating calcium levels. So they don't feel the hypocalcemia anymore. So they lead to decrease in parathyroid hormone release. Okay. And in clinical use, it's used to treat secondary hyperparathyroidism in patients with chronic kidney disease. So patients with chronic kidney disease, they have chronic hypocalcemia. So they have continuous release of parathyroid hormone, to the point that they lead to renal osteodystrophy, right? So it can be also used to manage hypercalcemia in primary hyperthyroidism if parathyroidectomy is not successful, or in cases of parathyroid carcinoma. And of course, the adverse effect is that you would have hypocalcemia, but you wouldn't have the corrector of hypercalcemia, which is the parathyroid hormone. I want you to solve some questions. So gliptins, okay? Don't mix gliptins with flozins, guys, okay? Okay, correct. So most of them are right, even weight loss. So it leads to weight loss, okay? But here, because I think adverse effect, it's not adverse effect, it's good. So anyway, so disulfiram reaction is associated with just first generation, which is chlorpropamide, and a little bit of tolbutamide as well. So it's not a main adverse effect. The main adverse effects are hypoglycemia and weight gain because of insulin secretion. Okay, so this is a trick question. Good job, guys. I'm so glad. So increased satiety here. We're talking about increased satiety. So amylin analogs and GLP-1 agonists and also DP4 inhibitors. Anything that works on GLP-1. Propylthiouracil is the answer. Methimazole is a teratogen. The main side effect is a teratogen here. Propylthiouracil, the main effect is, or the side effect is hepatotoxicity. Desmopressin is ADH analog, okay? So it's used to treat central DI, not SIDH. Okay, good job, guys. Nice. By the way, more points are given for faster answers. So nice. We just have 2 slides left and we'll be done. Okay, so cevilimere and the other one, next one, which is patiromere, both are binders. So they are ion binders in the intestines. Okay, so cevilimere is a phosphate binder, so it prevents the absorption of phosphate from the GI tract, and it's used to manage hyperphosphatemia, specifically with patients with chronic kidney disease. As you know, chronic kidney disease is associated with hyperphosphatemia because of the inability to excrete phosphate. Okay, adverse effects is of course hypophosphatemia or GI upset because of the accumulation of phosphate in the GI. Patiromere is the most important one here. It's cation exchange resin, meaning, in simple meaning, it binds to, it has some ions on top of it, so sodium and calcium, but it leaves sodium and calcium in exchange for potassium. Okay, so it binds to potassium. Basically, it's a potassium binder. With the easiest thing to was the easiest simplest terms. Okay, so these resins bind to potassium ions in the colon and exchange them for other ions or cations like sodium or calcium, which are then excreted in feces, leading to lower potassium levels. And it takes time, of course, other than, different from insulin. Insulin is direct IV, so it decreases decreases potassium very quickly, unlike this, which takes time till the potassium is excreted in the GI or the intestines. Okay, so the adverse effect is leading to hypokalemia or low potassium levels and GI upset for the same reason. Accumulation of potassium and here accumulation of phosphate. That's pretty much all about it, guys. Study